Megamind.
You're my mentor.
Thank you so much for having me today. And Mr. Weber, thank you for the kind support, what you give to me for all the lectures and all what I'm doing. Today's title for my lecture is The Guided Journey into Success.
By doing so, I would like to use my 15 minutes to show you everything I know about a new protocol, which I call the CEREC Megagen Guided Surgery Protocol. But before I get started, since this is really a celebration of ours, 20 years of evidence-based dentistry, I want to travel with you back in time. 20 years ago, if Mr. Park would have planned a trip from headquarters in Daegu to the place where we were yesterday in Gandam, he most definitely would have used a map, a piece of paper, and a pencil to get planning. On each and every intersection while traveling, he would double check, and if he get lost, most likely he would ask somebody who's knowledgeable and who knows the way. 20 years have passed, and most likely, Dr. Park, if you're gonna go for this ride, you would grab into your right-hand pocket, get your cell phone out, dial in directions, and press the start button. This system, technology, will guide you through the whole process of driving. Once you get lost, the system will guide you back to the right pathway. And it's basically the same within implantology. 20 years ago, most likely, we would all in this room would have relied on our own skill sets, our own bare hands, and the knowledge which we have received up to this point. However, times have changed, technology has evolved, and the patient's need is that we do the best treatment possible. And the best treatment possible is achieved with digital guides and with digital planning. So let me quickly introduce to you my present case for today. And I would call it the everyday case. So it's nothing special, it's what we do in every day, what you're all doing on everyday basis. So this patient, she's average, she's 68 years of age, she's on a drug list, so she's not on medication, and she just, like most of our patients in Germany do right now, just recently recovered from COVID-19. She, as you may tell from the CBCT, has a low demand for anesthetic outcomes. She really experienced quite a lot at the dental office already. And for us, it's an everyday case since we do have sufficient bone quality and quantity in the area of 25. However, there is a need for vertical bone augmentation in the area of 27. The synergy of the CEREC workflow with the Megagen AnyGuide system is the next level. The reason for this is that everybody who's capable of designing a proposal within the CEREC system is now happily invited to our Megagen family. Beforehand, it was not able to be introduced to our system because of our sleeveless design. However, opportunities arise in January, and we conducted more than 40 cases during this time frame, which I will show you. So what we do is we get the proposal conducted within the CEREC workflow. In this case, we start with the intraoral scan, and most likely, and which is very handy, this is not the first scan you did on the patient. What we do in our clinic is on each and every patient who comes into our clinic, we do first examine intraoral scans. Why is that? I will tell you in a minute. So this is the intraoral scan, and the CEREC system allows us to get a proposal done. So this proposal is then be utilized to be conducted and transferred to the CBCT software. So this is the CBC software going along with the Sirona CBCTs worldwide. So there are more than 40,000 systems installed at the present moment. And we superimpose the intraoral scan and the proposal conducted with the CEREC for the implant planning. And as you can see, there is sufficient bone quality in the area of 25, but we have a vertical dimension problem in the area of 27. I like that this is an average case. As you can see, it's 7 millimeters. So if we go with the AnyGuide protocol, we can drive as close to the Schneiderian membrane
using our drill bits from the MegaGen system. Once we planned the guide, we then transfer the information to a cloud software, and the guide itself, a sleeveless guide, is designed by AI. You receive it after 12 minutes, and then all you have to do is get the STL file to your printer. And there are a couple of very important steps you have to consider and you have to know once you get to start printing in your offices. And there are a couple of steps which are very important. Number one of importance is that you have a passive fit within your guide. So there has to be an offset within your printer, and that's something which is delivered within the slicer software. The other more important aspect is the way how we get it sliced and how we managed the inaccuracy in the area of the drill hole. So as you can tell, I'm removing the support structures over here in order to reconsider the placement of the support structure so it does not interfere with the drill hole itself. Then all you have to do is you have to dial in what kind of resin you're using. In our case, we use a system which is called Key Guide from Keystone Industries. Press the start button, and within 20 minutes, everything is done up to this point. Another 1.5 hours, printing and post-production, and then you're ready to go. One further step, and MegaGen already thought about it, is that there could be an issue with excess resin within the guiding hole. So if you have a look at this tool, MegaGen is the only company worldwide who's providing this at this present stage. So we're up front already. What is this doing? If there's anything excess within the guidance hole, it will remove it, and you will be perfectly fine to get going during your implant placement. So as I said, driving is something which Germans like. We have two pathways to drive today. An area of 25, we have to go all the way to our final parking destination, which is at length of 10 millimeters times 3.3. And for the Schneiderian lift, we go to a length which is adjacent or very close to the Schneiderian. So let me get to the point where we get started with a patient. We draw blood, and this is what we always tend to do when we go for Schneiderian lifting and indirect sinus lift. And this is how the blood clot would look like. We were discussing this at this table beforehand, and the guy from Australia said it looked like a schnitzel, but I wouldn't say it looks like a schnitzel at all. So he's really not using it, but I bet you it's the way to go for you as well. So this is how the intraoral situation looks like, and we do go for local anesthesia. And what we double check now is passive fitting of the guide. The passive fit means that once you apply the guide intraorally, it has to stick in place without any further ado. And as you can tell, it's perfectly fitting the situation, and then we go to continue to rise the flap. Whenever possible, I go for flap design without any kind of vertical incision. Why is that? Because we want to have the nutrition for our gingiva as good as possible, and whenever you do vertical incisions, you do take away a lot of the nutrition which is needed in the situation. So what we basically do then is we continue driving our pathway through the protocol of drill bits up to the point where we double check. We do remove the guides regularly in order to do double checking on two very important aspects. Aspect number one is, are we still on the right pathway? Because you can rely on technology, but your mind has to be on it as well. So if you misplace the guide somewhere within the drilling protocol, you can get lost in direction. So you'd have to double check on that. Second aspect is you always double check for fenestration defects on the buccal parts of your bone. So this was done and conducted, and it looked very good. We continued, and this is how our final steps looked like prior to the sinus graft. And as you can tell, normal ostomes was what we do in our offices daily. And this is how we apply the PRF in the extraction socket, in the implant socket. And as you can tell from this picture, we went all the way close to the sinus, 7 millimeters of vertical, and applying the PRGF membrane so that we are perfectly covering the Schneiderian membrane. So the rest is quite simple. We do have an implant placed which has a diameter of 4 times 10 in the area of 45 within the premolar, which is our most beloved implant there. And in the molar region, we go always for something which is a little bit wider, 4.5 times 10 millimeters. We do check for initial torque. 35 and higher is what we try to achieve. And as you may know, and more of colleagues will call you tomorrow and will tell you about it, is that the ISQ value, the MegaGen ISQ value, is very important to monitor our outcomes. So we do this, and basically we do the final steps with the patient. We place the cover screw and we suture it up. On normal presentations, this would be the end. But to be honest, why is the patient coming to us in the first place? Well, she has a demand for us. She wants to have teeth. And if we leave her like that, we didn't achieve the whole thing. So this is not the final picture. This is a final picture for us dentists saying, well, gosh, nice placement. The Schneiderian membrane is lifted and the X-ray looks good. However, the patient still needs some more from us. And this is the reason why I think it's very important to deliver more. And to deliver more in this case means she has needs for teeth. She wants to smile, and she wants to smile right after our procedure. So what we did then was that we continued for a provisional. And this provisional is exactly the situation as the one it was prior to the extraction therapy we did. So we were able to use the intraoral scan we had made in the first appointment. We then superimpose a base, which we constructed with the Exocad software. We did a new scan, and we superimpose the image from the first scan. So this is the situation, exactly how the patient came in the office for a first appointment. So she knows the bite, and we don't have any issues with TMJ in the later run. And what we do then is, one more time, we hit the start button in our printing process and printing protocols. We do print the base, we do print the teeth. Our technician is gluing the stuff together. Also, very convenient, very fast. It's a process which not longer takes than 3 hours. And basically, this is the provisional in the situation like the patient came to our office in the first place. And my final image is how the patient leaves the office with teeth. She is able to smile now. Thank you for your kind attention. I would like to say thank you one more time to MegaGen and to the MINEC community for giving me the opportunity to be here. And thank you for the guys over there at the table. It was really quite a trip yesterday. I really appreciate everything so far. Thank you so much.
Megamind.